afternoon and welcome to this IORMA webinar. Before we get underway, I would just like to say a few words about IORMA Global Commerce Centre and make a few housekeeping points. The IORMA Global Commerce Centre is a neutral resource for businesses and governments that recognise the need to understand and respond to the ways in which the 7.8 billion global consumers are changing in the products and services they want and need and the ways in which they want to obtain them. And these things are changing globally, driven by developments in society, in business and in technology. This webinar is one of a series of thought leadership discussions that are held typically every other Thursday, and they're chosen from IORMA's Horizon Scanning, its surveys and research. Now, it's my pleasure to be host and moderator for this session. I'm the Virtual Conferences Director of IORMA and also Vice President of the International Society of Digital Medicine. Now, before I introduce our panel, I'm going to now switch to a gallery view. I would like to put a polling question up as a way of setting a bit of context to the discussion today. So I'm launching this polling question now. So you should see it on your screen. And what I'd like you to give me an idea of where, or your opinion on where the biggest impact of technology on hospitals of the future is likely to be. I put up 4 different options, and the first 2 are relating to the kind of technology that will be used within hospitals. And the first one is hospital and patient administration systems, so things like digital health records, etc., digital patient records, resource management systems. Or, again, talking about within hospitals, is it likely to be patient diagnostics and treatment systems, MRI scanners and robotic surgery, etc.? Or are we likely to find the effectiveness investment outside of hospitals in telemedicine solutions for remote care and rehabilitation, or preventative healthcare solutions? And it's interesting to make the point in putting this polling question up that in a way that I'm prompted to use these questions as a result of a new book that's come out, which reflects on some of the challenges faced by the National Health Service today. And a lot of that from the review of the book seem to be related to the problems associated with the fact that many hospitals are not digitized and the records are not available to everyone. So I'm going to end the poll now and share the results with you. You should be seeing those on your screen now. Okay, thank you very much for that and welcome to our session. I'm going to now ask each of the individual panelists to introduce themselves and say something about their background and their interest in the topic of discussion today. I'm going to start with Nora Colton. Nora.
Hi, so my name's Nora Colton, and I am the director of the Global Business School for Health at UCL. It's a new school. It's the first business school in the world totally dedicated to health and healthcare and that intersection between healthcare and management and leadership. So I myself am trained as an economist in both development and health and have a particular interest in digital solutions.
Thank you very much, Nora. I'm now going to go on to Pelham Allen and ask Pelham to tell us about himself.
Oh, good afternoon, everybody. It's a pleasure to be here. I'm an accountant by background, but most of my recent career has been in corporate turnaround, and my engagement with the health sector was prompted by being an inpatient treatment for cancer and realizing how appallingly badly hospitals seem to be run. My focus is particularly on organizational effectiveness generally, but in the context of today's seminar, I'm very interested in the way in which technology both precipitates organizational change, but also requires organizational change. So look forward to participating in the conversation.
Thank you very much, Pelham. Now I'm going to go to Steve Dunn. Steve.
Good afternoon, everybody. It's a great pleasure to be here. I'm the co-founder and chairman of Medical Realities, which is using XR technology to train and educate healthcare professionals and patients around the world. My background is pretty varied. I originally started off in film and television special effects, but over a number of years transitioned to sort of going into gaming, applications for mobile phones and new technology. That eventually led me into augmented reality and virtual reality. And then I had a very good serendipitous event where I met my co-founder of Medical Realities, Professor Shafi Ahmed, who was speaking at Google Campus. And we started talking about how new technologies, especially immersive technologies, could help in medical training and patient education. So that's me, and that's the start of Medical Realities.
Thank you very much for that, Steve. And last, and certainly not least, I'm going over to Jeremy Russell to get him to tell us about himself.
Thanks, David. Good afternoon, everyone. My background is as a scientist and technologist. I've spent the last 30 years in medtech developing products. I've probably been responsible for bringing maybe 80 to 90 new medtech products to the market. I'm currently CEO of a company that develops surgical robots. And we have been looking at this whole situation and developing low-cost, affordable robotic solutions, both for the UK and for the international markets.
Great, thank you very much for that, Jeremy. So now I'd like to go on to the first question that we want to discuss, and that is to ask our panelists, and by the way, please, when you are participating in this discussion, please use the Q&A box to ask questions. I'll be keeping an eye out on that, and that makes a valuable contribution to the discussion. We want this to be as interactive as possible, so please use the Q&A box rather than the chat box for if you have any questions. But our first question is looking at what technology is able to make the most significant transformation in the treatment of patients. And we've got a few options here: robotics, virtual reality, digital laparoscopic surgery, etc. A range of different things. I'm going to go here initially to Steve Dunn to ask him for his view on this.
Yes, thank you, David. Yes, helping patients and reaching out to patients wherever they may be. I think immersive technologies and mobile technologies are certainly something which can really help in these situations. Medical Realities is working on products which actually sort of help patients. And when I'm talking about XR technologies or extended technologies, I'm talking about mixed reality, virtual reality, and augmented reality. So there's a whole sort of palette of technologies that we can actually use, which I think will help patients going forward. And that's actually sort of from diagnosis, remote diagnosis, but also helping patients to understand what they're going to go through, all the way through to, in actual fact, actual treatments of certain things like phobias. There's a whole list of things that I could sort of go through where we can actually adapt immersive technologies in order to help patients in their sort of journey, wherever that sort of touches the healthcare market. It starts possibly from even preventative medicine as well. So we can actually sort of help from hopefully getting people fitter, understanding their bodies better, but also then what it's going to be like to actually sort of getting diagnosed correctly, but also helping them through their journey that they're going to have in the healthcare sector, right the way through to recovery and rehabilitation.
Can I just ask you about virtual reality, because it's something that's probably not that familiar with our audience, and in particular, virtual reality may be used in surgical operations. Now, I know that your company's been involved in what you might call live streaming in virtual reality of surgical operations, so that people who are not physically present in the operating theatre can actually watch and learn from the experience. Can you say a little bit about that?
Yes, absolutely. When Shafi and I started off Medical Realities, we started concentrating on surgical procedures because firstly, he's a surgeon, and we felt that was very relevant. Of course, surgery involves an actual patient, but it also involves a patient's family as well. When we're sort of dealing with live surgical events, we have to be very cognizant of the fact about sort of patient privacy, etc., but also privacy for the family as well. And one of the very first live surgical training events that we held at Bart's in the Royal London Hospital in East London, we in actual fact got permissions from everybody has to sign off privacy agreements, whether that's the surgeons taking part, or the nurses, but also the obviously the patient, but also we get the families to sign off as well. And one of the things that we discovered, we were quite surprised about this, that when we actually did the operation that was available via downloaded app, we didn't expect the relatives and the family of the patient to actually want to watch the operation live. But in actual fact, they all did. They all insisted actually that they wanted to see what was going on. And they said that they actually felt really sort of calmed by what was happening, because up until then, really, the sort of what happens behind the closed doors of the operating theatre remains a mystery to most people. Even a mystery to actually nurses and people in the hospital themselves. And so that because they could see what was going on and they felt that they were connected to what was going on, they could see everybody actually was working very precisely, very professionally, and they felt it actually helped them get over the anxiety of watching a loved one being operated on. So that was quite a surprise to us.
Yes, and I believe that that operation was watched by other medical professionals and surgeons around the world. Can you give us an idea of how many? And also just make the point that they didn't necessarily have to have a very expensive virtual reality headset. They could use a mobile phone within Google Cardboard. Is that correct?
That's correct, and it's always been one of our sort of balancing acts that we have, whereby it's great if you have access to the latest virtual reality headset, but we want to make what we do available as widely as possible. And so everything that we do is available either on Google Cardboard headsets or actually on mobile phones or tablets or laptops as well. It was interesting that of all the people that joined in to watch the surgery, we actually had nearly 2,000 people actually working at the Royal London Hospital, actually watching the operation themselves. And the total number of people that actually watched that operation live around the world was 55,000 people in 142 different countries. So it actually got a lot of interest, and we in actual fact got a lot of feedback from people from around the world, whether that be in Bangladesh, Australia, the USA, and also China. So it was very successful. And I think it sort of shows how we can use immersive technologies such as we're producing to actually sort of really scale and reach out to people. And of course, like this webinar, it's recorded, and people can, if they can't see it live, they can actually sort of catch up on it later. And we've had nearly 750,000 views of that particular operation since then.
Thank you very much for that, Steve. Sorry.
David, could I come in there?
Yes, please.
So, Steve, I think that's really interesting, but I would just challenge a bit about you know, and again, I think this brings up a wider issue that we need to touch on, and that is kind of the need for urgent research to really understand this, and you know, particularly in terms of patient benefit, and also the pressure, you know, live surgeries. I can assure you there are many surgeons who would feel uncomfortable with that. They would, the stress that it puts, and if things go wrong, you know, so and then I think the other thing is, it's some of these technologies, and particularly because of COVID, they're relatively new, and so we haven't seen the research at scale to just understand, you know, all the consequences. So I'd be interested to hear your thoughts about that as well.
Yeah, they're very good points. In actual fact, we consider all that, but really the sort of the simplest surgery has possibly dire consequences, because surgery by its very nature can lead to complications, and unfortunately can lead to death. So everybody has to understand what they're signing up for. But I'm immensely proud and of the surgeons that actually sort of every day sort of step up and save people's lives, and you know, just to actually operate on a person, whether they're being viewed by other people or not, they have my greatest respect. Obviously that we have procedures in place to in actual fact make sure that we cover all the possibilities of what might happen. But I'd also point out that just recently, well, actually going back to the 50s, there was a live TV program called Life in Your Hands, which actually showed live operations on the BBC from operations. And it was one of the largest, highest watched and highest rated programs of that era. And since then, both BBC and Channel 4 have in actual fact transmitted live operations in the UK in the last 2 or 3 years. And to your point, we've been doing this now for over 6 years. We actually have a lot of research about what we're doing, and also research from other people around the world about how to use immersive technologies effectively and safely.
Thanks for that, Steve. Can I just go on now to Jeremy? Jeremy, robotic surgery. Can you just say a little bit about that and some of your thoughts on that? Because we've got some questions coming in about robotic surgery.
Certainly. I mean, ever since I've been involved in medtech, everyone tells me that the demand, healthcare demand, is growing at 2-3% a year, and that is true. And it's something around the world that continues to grow. It's not static, and it is something that the demand on healthcare systems around the world grow continually. And I'm often asked, as the CEO of a robotic company, well, isn't it just toys? Do you really need to do it? And my response is that every bit of medical technology we should use it when it can do it better than a human, or when it can replace a human. We have huge amounts of shortages of clinical staff in healthcare systems around the world. There are various figures that are quoted, but I was quoted recently well over 1 million clinical staff vacancies globally. And my view on this is that if you've got a robot that can do something more effectively, more efficiently, and can free up staff to do another clinical task, which can't be done by a robot, then that is a really valuable contribution, which is the approach that we've taken to robotic surgery. I think robotic surgery, I think there are many tools for getting the best possible view of what's going on in a surgical procedure, which includes using 3D and even virtual reality. But ultimately, we're some way away from surgery being done without the skilled surgeon there on a practical level, at least. And so certainly for the foreseeable future, we should be looking at robots to enhance what we're doing, to make surgeons better, to remove variability in procedures, and to replace staff who may be doing a routine task that a robot, a surgical robot, or indeed in many other areas of medicine, interventional medicine now, can do something much better.
So do you think robotic surgery helps with a level of precision? Because this is something I've heard in surgery for prostate cancer, is that the outcomes with a robot surgeon operated by a skilled human being can actually deliver more precise results with less collateral damage.
I think that generally, I think that there have been many clinical studies looking at this, but ultimately what we're talking about for what we may consider classical robotic surgery now is that you're getting precision and control. You're getting a better view of what's happening at the site, and you're getting better control of the instruments. I often compare it to, for our own robot, which focuses on holding the endoscope, the laparoscope. I just sort of say everything that the surgeon done is dependent upon the quality of the image. And so therefore, if that's stable and accurate, it is going to be much better than a human being trying to hold something in an unstable manner. Or as I sometimes say, you know, it's like trying to thread the eye of a needle when on the top of a bus. It's not going to be easy. So you want the best possible image by which to operate by.
Yes, you're starting to depress me there with that kind of analogies. But just extending that a little bit further, I know that we've already seen a robotic surgery devices controlled remotely by people who are not in the operating theatre. What's your view on that?
I think all things are possible, but I think we have to remember that clinically we have a human being and we have a duty of care to actually what's happening there. I think it's perfectly possible to drive a robot from a long way away. It's where some of the original thinking came from anyway, but it becomes slightly less relevant if you've still got to have someone right next to the patient, another surgeon next to the patient anyway. But it certainly does open up a number of opportunities, particularly for complex surgeries where you can potentially have someone at an external site who can assist or help with key parts of the operation. And that certainly is something that I think is possible nowadays. I think one of the things as we look forward is to say, we're going to get increasing specialization in medicine and in surgery. The idea that you go to your local hospital and they can do everything, I think, is one that is frankly economically not justifiable or affordable. And so increasingly, we're going to get what I think are going to be super specialists. We will aggregate certain types of surgeries in one area. And then you will have these super specialists who may well then be able to use remote or robotic means to assist surgery and activity using some of this technology in other centers. But certainly that's how I see things will move over the next 5 to 10 years. And all of these will support good surgical practice. I don't think everything will go one way or another, but I think it will be a combination of these technologies that can be brought to bear.
Okay, thank you very much for that, Jeremy. I now want to move on to a different kind of tack, and I'd like to bring in Nora here. Now, Nora, you're starting up this new initiative at UCL, and a lot of this would do with the management and leadership within hospitals. So what changes in management and leadership do you think will be required to bring about some of the more radical changes in the delivery of services to patients?
Thank you, David. Well, first of all, I think we have to realize, you know, what we're going through and what we're talking about is really transformational change. And that tends to be the most radical type of change an organization can experience. And so it's not just about new systems and structures. It's really about an upheaval of existing ways in which we have practiced medicine for decades. You know, so when you have this kind of transformational change, you then have to think in a much more holistic way. And that's why we often hear people talk about systems thinking. And I think that for me, that really is extraordinarily important. What we see is that, you'll get a doctor, a physician who will come in and use a robotic in surgery. That to me is not transformational change. That's not changing the way that we do things. And so I think, it's moving beyond just tinkering at the edges, as it were. And it's really, how do we reimagine healthcare in this technology space? And I think it, first of all, has to start with a kind of holistic strategic approach. And part of that really then starts throughout the organization. And it's not just about down in the operation rooms. It's really right up at the boardroom. You need that kind of commitment by the organization to really have a vision of how they're going to use and implement technology. And then, on the executive level, that strategy that's agreed and then implemented. Because I think we're in danger right now. We're particularly in the post kind of pandemic period, where we relaxed a lot of regulations, legislation. In places like the United States, it got much easier to implement and use technology, via different payers and insurance companies. And so we have a lot of what I would say stuff out there. And it's how do we now pull that in? How do we do the research at scale? How do we know how to prioritize it? Which things are really making a difference for patients, and which things are just, what I would call displaced activity, quite frankly. And I think that is really important work that organizations have to do. I think one of the issues that we face is that many times our senior leaders are not necessarily themselves trained up enough to understand that digital space and technology. And so it starts really not just with the clinician, as it were, but it's got to be really, as I said, holistic throughout the organization. So we need to think about patients. How do we co-produce with patients? How do we bring them in early on into the design? How do we work with our care teams? How do we ensure that the implementation of digital technology and technological change in healthcare is led by our care teams? And then, of course, it's as I said, thinking about the governance and the organization itself. And then last but not least is that wider organization that all of this sits in, and that is the exterior environment, whether that's the healthcare system, whether it's the legislation and policies and practices and guidelines that sit around digital innovation. And I think this is all very important, particularly in a time when we see access to healthcare increasing. We have aging populations. We have more non-communicable diseases, not just in developed countries, but low-income countries. All of this is then in an environment where we're calling for a reduction in costs. So I believe that there are really some fantastic innovations that will make a huge difference. I'm a big fan of remote patient monitoring, both in terms of people who with chronic diseases, also shorten hospital stays. But I think it all has to be contextualized into that larger kind of framework of leadership and management, because if it's not, then it ends up being, like I said, often displaced activities. We hear a lot about wearables. We don't really have much research on the impact. We don't understand cohorts or subgroups of patients and what the impact is there. So all of this is really integral to getting this right. And if we can get this right, I do think it can be transformational.
Okay, thanks for that, Nora. So we're looking, you suggested a more holistic approach to it. Pelham, you've been involved in turning around some hospitals in the future. What kind of problems have you encountered, and how do you see technology addressing some of those problems?
Well, I'm actually going to come at it, David, from a slightly different point of view. There are some miraculous developments in technology, both sort of medicines, kit, digital technology, all sorts of things are possible that were not previously possible. But they require changes in the way that people within the medical profession work. Because the idea that somebody can be in the profession over a long period of time, develop experience and expertise, and use that through their career is significantly impacted by the fact that the context in which they're working is going to have significant change. I had the experience in London Cancer of introducing a concentrated robotic surgery service for prostate cancer across a number of major hospitals. And it was very interesting, really. The challenge was to get the workforce, the very senior and experienced clinicians, firstly, to come to terms with the way that they would simply operate differently. Secondly, that they would operate in a different place quite often because the robots were not where they traditionally worked and were in a smaller and more intensive unit. The nature of their relationship with the patient also shifts because surgeons become a little bit more like doctors, if you like. There's less emphasis on their mechanical skills because to a certain extent that is taken over by some of the kit and perhaps is dependent upon people using that kit at an earlier stage in their career. And there's more emphasis on their skills to actually relate to patients, to interpret different signals, and to make clinical judgments rather than actually perform clinical functions. So it's very interesting. The introduction of technology really leads to changes in the way people work that are not always anticipated, but can, of course, free up expertise to be used in a much better way.
Yes, you make some interesting points there to do with the impact of technology and on the way in which organizations operate. I can think of a couple of questions that I'd like to throw into the mix that I think are relevant to that. The first of these really arises from what Nora had to say about adopting a more holistic approach to the way in which healthcare systems are run. Now, it seems to me that although the health service sector is not unique in this respect, people progress through the health services through their discipline. So in other words, you go up the chain based on your experience. And does that necessarily mean that we need people with more external experience of other organizations and digital transformation at high levels within the National Health Service and other organizations? Will they benefit from that? Nora, what would your thoughts on that be?
Yeah, well, I think it's again, and you know, Helen mentioned it, it's really about education and digital literacy. And I think sometimes we assume many things about people's knowledge base. So I think I'm not sure that we necessarily need lots of external experts. We've got lots of experts. I think it's also understanding those capabilities. And you know, one of the things that I've seen in a number of organizations, and I'll come back to you know, this point again, is it's right, starts at the board level. Often our boards, and so if I was going to pick a place where I think we need to start to make change, it's at who sits on those governing boards and the kinds of skills that we put on those governing boards, because if those individuals are not comfortable and understand, they are key decision makers in all of this that kind of trickles down into the organization. I think there's also a disconnect. We often focus on clinical staff, and as Pillen has just rightly said, you know, there'll be new roles, and those roles for clinical staff may evolve. It may mean that they can do more, and I've seen this particularly with telemedicine, and you know, I was at Moorfields Eye Hospital, and I saw them do a wonderful job. The number of patients that they could see by using you know, telehealth. So I think it's not necessarily, we need different skill sets, but I think we have to be careful about assuming that the people there in our health organizations cannot adapt, cannot be agile. I think they can be, but I think we need to have programs and abilities to do that. And I think it really starts with medical education, you know, how we train up people from the very beginning. I think we need to work with our, you know, the accreditation processes and boards that facilitate that, how we incentivize people to get different kinds of CPD experiences, you know, professional accreditations and credits. All of our professionals have to do that. And I think it's the kind of nudging and signaling that goes beyond that. And then I do think that there is something to be said for widening and creating more breadth of knowledge. I think we've gone through as really a society, and I can say higher education sees this, we need more people with T skills, people who can really have that breadth, but also combine it with that depth. And so I think it's a really interesting opportunity. And as people hopefully live longer, I would imagine as a medical professional, I would really want to be able to change and evolve. And I think we would probably, you know, and one of the things I've read actually about, you know, the use of digital health technology is it does help alleviate stress and burnout. And so, which are two things that are really, you know, on the minds of any person in a senior management role in a health organization right now. So I think anything that we can do to help widen that kind of understanding. But I think, just lastly, I'd like to say, I think we've got lots of technology and lots of great ideas out there. It's how do we take those ideas and bring them through actually a workforce that feels very demoralized, overworked, undervalued. And I think that's the real challenge here.
Okay, thanks for that, Nora. Yeah, I can't help but agree with you on that, and I think maybe we can touch on some of those technologies. I know Steve will have some experience on digital therapeutics to help with stress management, but I want to go to one of the other points that Pelham made, which was really talking about how jobs will change with things like robotic surgery. And he gave an example of a surgeon moving to be more like a doctor, in the sense that his job is no longer dependent upon mechanical skills. Digital technologies have a great potential to empower staff at all levels. So does this mean that, for example, nurses and other clinical practitioners will be able to take on more complex roles than they've traditionally had been able to do in the past? And will this in itself help to alleviate some of the problems? Pelham, I'll give you a chance to answer that, and then ask Jeremy for his opinion.
The short answer is yes, because effective digital systems mean that the amount of knowledge that a particular person has to carry in their head is reduced. So, there was a time when if you saw a doctor, you wanted to see a doctor who got at least 30 or 40 years of experience, because they'd need that time to accumulate the wisdom to work out what the hell was wrong with you. Now there is so much more scope to digitally support that type of diagnosis process that actually it can be delivered by people who have obviously an appropriate degree of experience, but are not expecting to carry all of that experience in their heads. So I think there is immense scope for nursing staff, allied health professionals, and others, and in this context, probably also junior doctors, frankly, to deal with problems of more complexity and less common situations than they would have been considered able to do so historically.
Yeah, thanks for that, Pelham. I'll go on and ask the same question to you, Jeremy. What's your thought about the way in which roles will change as a result of technologies like robotic surgery?
Well, I think that, I think there's been a change over the last 20 to 30 years anyway, in terms of what, for example, nurses traditionally used to do. And a lot of that's being driven by education and changes in the approach, and again driven by this, the great demographic thing, which is always challenging us in healthcare. But I think I agree with Pelham, because I think we will have to find ways to use our clinical staff to the best of their ability. We have to do that. We have to find a way to maximize the work that they're doing is valuable work. And that will mean, to some degree, going back to, I mean, it's like I've run factories in the past. When you need to sort a factory out, you go back to the beginning and you try and understand everything and find out where people are doing things and think, why is that qualified person doing that? They do not need to spend doing that. We could get either a machine or someone less qualified to do it. So I think there's a, as part of this overall change, what we will have to do is to think about where value is added in any part of the healthcare process. Robotics is one little bit about this. Information, availability of information, where we treat the patient, where we see the patient. These are all part of the things. I mean, we've seen a huge change in general practice during the pandemic, and that is unlikely to go back to how it was. So I think the answer is yes. I think the goal is to try and say we've got these clinically qualified people to get them doing things where they're really adding value, and to find those areas where we can use robots or some other form of information management or something to replace them is imperative. I mean, just an example, in a UK hospital in the last 3 years, to order something, I found someone would handwrite it, would fax it internally within the hospital. It would then be written back into it would be then entered onto the system, which would then be printed out and sent to someone for 2 signatures. That was for a standard consumable order. So I think it's an exaggeration, but that is where the sort of thing we have to go in and say, why are we doing this? And sort of rebuild. And it goes from that level all the way up to, what are all the people doing in the operating theatre? Well, we've always had a spare person. And so I think there's a lot to come, and there's a lot of opportunities. And I think, but it does mean we have to go back to the beginning and say, what are we doing in the whole process, and who does what and where?
Yeah, thank you very much, Jeremy. I'd like Lola just to touch on something Nora said about the stress that the clinical staff are feeling these days, and introduce the idea of digital therapeutics and the use of virtual reality and immersive experiences as a therapeutic treatment that could have value to clinical staff and give them some not only the clinical staff, but of course patients who are suffering from phobias. Steve mentioned this in his earlier discussion. Do you want to try to expand on that a little bit, Steve?
Yes, David. I think also I'd just like to sort of point out that Yale University has done a study recently that VR-trained surgeons were 29% faster and made 6 times fewer errors than surgeons trained traditionally. So I think there's lots of scope here that where immersive technologies can actually sort of build on what's already there, but actually make what's already there even more effective. We, for instance, although we started off on surgery, we've actually expanded out now to be much wider ranging. And where we first concentrating on medical students, we now also do continued professional development for healthcare professionals around the world. And part of that, as you say, is actually what's great about using these new technologies is that you can actually train people about empathy as well. They're very good for actually sort of training people how to deal with patients or how to deal with other colleagues. And I think that also helps towards the understanding of how you can actually sort of deal with situations inside your trust or your hospital, but also that you can actually sort of learn to deal more effectively with patients and learn to understand their concerns more clearly. And going forward with patients, yes, there's just so many different ways that we can actually sort of help in actual fact, adding to what's already there. for instance, that there was a few years ago, I had a very serious operation, and I was very well looked after, and it was fantastic. And the rehabilitation immediately after the operation was fantastic. But after 6 months, that rehabilitation was effectively cut off. And what we can actually use is new technologies like immersive technologies in order to help people continue with that and sort of and take the strain off having to go into hospital and actually having to do the rehabilitation at hospital because simply there aren't the resources to do it there.
Yes, I think remote care and telemedicine and technologies that help people to carry on rehabilitation and treatment and being able to be cared for at home will I think act as a great support for hospital services. We're getting some good questions in the Q&A. Before I go to those, I want to leave enough time to deal with some of those. I would like just to ask Jeremy another question, and this is whether we can learn anything from overseas in the way of what's being done for surgical treatment, hospital care. What can we learn from overseas organisations, Jeremy?
Well, I think there's two ways of looking at sort of both in and both out. And what I mean by that is that working with different countries continuously, and you realize that a lot of countries take a different approach to the way that they prioritize things, the way that they operate from our perspective clinically. I think one of the things, for example, I think that sometimes when I look at the German hospitals is very often in the clinical structures I'm talking about here, they're much more structured than we have in the UK. So that there will be a head surgeon, and then the surgical team is very much in a group together, and they go as one, as it were. Whereas often we have in the UK, we will have, we often joke, we go into a hospital and ask them how they do a procedure, and there's five surgeons doing the procedures, and they do it 6 different ways. So I think there's lots of things that are interesting around that, and I think we could talk for a long time as to why that is. I think what has been interesting for us as well is that the COVID drove us to, we couldn't travel anymore, and we couldn't take our technology and introduce our robotic technology overseas. And so what we did is we developed a remote training methodology so that we could train people using standard platforms, nothing fancy. So we have managed to train surgeons internationally, and we've launched our product, and we've had it used internationally, particularly in the Caribbean, without anyone from our country ever visiting. I have to admit that I've actually sat at this desk while they've done surgeries in the Caribbean, and they say, "Ask Jeremy, what do we need to do now? Where do we need to position the robot now?" And it is a slightly surreal experience to spend an evening doing that. But I think what that has done is it's opened up our eyes as to how much we can achieve and how much can be achieved without actually having to go the traditional ways. It says we've got to be there. Because initially the surgeons in the Caribbean said, we'll send a proctor over, we'll look after them, and everyone was volunteering to go, of course. But actually, once you cut through that, you realize there's so much that can be done without having to invest in people traveling and people being present. So we've been amazed by this, and are now training people in the Far East and other countries remotely without traveling to those countries. And I think what that does is it makes us realize what the potential is to train and to support remotely without having to use very, very expensive, fancy methodologies. I mean, we used Google Meet and built it all around that, and it worked perfectly. So I think there's much to learn from observing elsewhere, but I think there's also much that can be done as we operate on an international basis, that we don't have to be completely just thinking UK, but we're thinking much more broadly.
Well, yeah, thank you very much for that, Jeremy. I'd just like to now move on to some of the questions that we've got, because we've got about 10 minutes left. Just have a look at see some of these we've already had answered. Question from Jane about technologies helping surgeons perform surgery more effectively. I think we've discussed that. Paul Epping asked a question: what's the relationship between robotic surgery and VR? Do we still need surgeons? You know, when are we likely, if ever, to reach the tipping point where robots will be able to do pretty much most surgery? Jeremy, I'll go to you for that one.
I sort of mentioned this in passing when I was speaking earlier. We're a long way from that tipping point yet, I believe. I think in theory all of these things will come, and I suspect what will happen is, rather than we suddenly go to not needing surgeons, there will be parts of procedures or little bits of procedures that will be able to be done sort of more automatically, if you like, or by the robot, because they can get increased precision and increased control. But it will be a stepwise process. But I think we're some way from doing that, not only because of the practical aspects of it, but because of the regulatory pathway that would be needed to approve a technology that could do that. And that would be an immense process to go through in order to ensure that something was safe and effective in that way.
And Jane asked another question. Could robotic surgery help in remote areas, for example, in India or Africa, or even Warzone? So, Steve, would you like to come in on that?
Oh yes, I think it definitely can, and I think that's also allied to. I was just going to make a point to follow on from what Jeremy was saying, that in actual fact the use of extended reality or virtual reality, especially in planning for operations, is that you can actually experience things in three-dimensional reality. For instance, I've been greatly impressed by neurosurgeons working in California that actually pre-plan operations in virtual reality, because they can actually sort of fly around the brains of the patients that they're going to do the operation on before they actually do it. And of course, knowing exactly where a tumor or whatever it might be is located in the brain, and what the problems are of actually sort of getting that out in a very complex three-dimensional space. They can actually sort of try that out before they actually do the operation. So I think that helps them. And also, as a byproduct of that, it also has helped the patients understand what the operation is going to do for them, and how the operation is going to perform. And I know that that they've had 30% more people have opted to have operations than before, who would have demurred because they simply didn't understand how complex it was, but also they didn't understand how good the outcome could be after it was done. And of course, we're looking at ways of being able to, and this goes back to sort of, do we have to have people that know everything about everything? Can we not train people about specialist things that are required at that particular time? Unfortunately, we've been doing some work with the US military in a good way for the last, just recently, has been the first time that the US hasn't been involved in a war around the world. And when they were in Afghanistan and the Middle East, their frontline surgeons had a lot of knowledge and treatment of specialist injuries, particularly from shrapnel and explosive devices. Now this has helped. The sort of like when they were doing it day in and day out, they got very good at what they're doing. But of course, they don't do that anymore. So if they're confronted with these type of specialist operations that they have to do, they're a little bit behind the eight ball. They haven't had the experience. We can actually sort of help recreate those operations in simulation, so they can practice on something that we hope that they'll never have to do, but they can actually be pre-armed to be able to do that.
That's a very important point. I've got a couple of questions about leadership and organisational change, and also the role of technology that I'd like to pose to Nora. We've had a couple of questions, one from Christine Elliott and one from Paul Epping. Christine Elliott says, surely transformational change will not happen without empowering all levels of the organisation, enable decision and change to happen at the earliest possible stage, leadership not being prerogative of the boardroom alone. And Paul's question is, what's the opinion of the panel that technology is actually contributing to increases of costs in healthcare from an OECD report? Nora.
Yeah, so I think, you know, what I was alluding to there around the board is that often those kind of financial decisions and the strategy is made at that level. But absolutely, it has to be holistic. It has to, you know, I think one of the mistakes often made is that decisions are made up at the top and they don't trickle down. There isn't the kind of connectedness. So I absolutely am not advocating it is a whole organization, but in terms of those broader financial decisions, I think sometimes what happens is there's a little bit of money allocated, and to really get that holistic change, you have to have all those levels, as I said, patients, the core team, the throughout the organization, all aligned, and often that external environment as well with the government. So that it's holistic, but I think sometimes what happens is you will get some change. You'll get an individual clinician who takes on a project or someone here. And if you want that holistic approach throughout an organization, it does require the top to understand and to buy into that, as well as those people down below. And so, you know, I think going back to, you know, education and training and bringing those frontline people, but I'd also want to just add a caveat, and that is, you know, when we're talking about all of this, people in low and middle levels within hospitals often do end up redundant. And I think we have to be realistic and honest about that as well. You know, so, you know, we often talk about, you know, kind of healthcare and all the shortages, and there are of course shortages, but we're talking about really evolving the whole entire piece. And I think we have to be transparent about that. And then in terms of, you know, just the value add and the cost, of course, it's going to cost more in the short run. You know, because when you're implementing a lot of change in technology. So again, it's having that longer term view, thinking strategically and not just focusing on the immediate. I think some of these changes, they have to often sit alongside. So you've got a robot over here and you've got someone, you know, still doing it the old way. And so I think that we have to recognize that change isn't, you know, instant. It takes time, it takes transitioning. Organizations will often, and then it gets back to a point I made earlier on about prioritizing and making sure. So great, we've got, you know, a study from Yale. We need tens of studies from Yale on all sorts of different aspects here. And we need that research at scale so that we understand what is actually working, where do we want to prioritize, and then how do we fund that accordingly.
Okay, thank you for that, Nora. Well, we're getting very close to the finish of this. I just would like to close with a couple of questions relating to more to do with the patient and the patient change. In fact, we had Paul Epping saying that not only changes in clinical staff and labs, drug discovery, etc., but the patient has to change as well. And then also Michael Phillips was talking about diet being the single biggest cause of growth in demand on the NHS and all Western health systems. So do we need to change the patients? And I'm only going to give each person just 30 seconds, please, just 30 seconds to say, do we need to change the patient, and can technology help with that? Pelham, I'm going to start with you.
Sort of the immediate reaction is that the majority of patients are already changing themselves in terms of access to, when you go and see a doctor, you Google your condition first and all that sort of performance, which is good. I think where the patient does have to change is we have to have better ways of supporting patients who, for whatever reason, can't do that themselves. So the sense that patients actually need to have help and support to navigate the health system as it becomes more complicated and sophisticated, that needs to change.
Okay, thank you for that. Steve, very, very quickly, 30 seconds.
Yes, preventative measures are always better. And yes, get at the start of things before they develop. Yes, so it's something that we have to concentrate on.
Nora?
Yeah, of course. And as Pelin said, I think one thing about the pandemic is it's really heightened people's interest in their own personal health. So it's about really seizing this moment in terms of patient education and making sure that people are really tuned up and engaging in that journey. And I think we read more and more about patient-centered approaches. And one of those is, again, I mentioned this, all of this needs co-production with patients.
Thank you. And finally, last but not least, Jeremy, very quickly.
Well, firstly, I think that everybody has probably said it all already, but I think it behoves us to remember that the patients are at the heart of of healthcare. It is good to have education. It's good to have support throughout all our journeys as human beings on this earth. But I think it's good that we need to remember that they are at the core of what we do. And my view has always been that every patient that comes into the operating theatre deserves the best quality procedure and the best opportunity for the surgeon to do the best they can for them. And so I think we need to remember how important every single patient is, and that should drive us to provide excellence in everything that we do.
Well, I think that's a wonderful way to close. And as Jane has just indicated in chat, it's a shame that this discussion has to end, but we need to be conscious of the time. And just to say thank you to everyone who's participated, all of our panelists, a fascinating discussion, and also to our participants as well for their questions and being with us. This event has been recorded, so it will be available in a few days' time on YouTube. So it now remains for me just to remind you that when you log off from this webinar, you will be invited to fill in a questionnaire. And so I would ask you when you sign off, and we ask you to sign off pretty much now, when you log off, please complete our feedback survey to give us an idea of what you thought of this event, ways in which we could improve it. And even if you want to make contact with any of our excellent panelists, there's an option to select that as well. So thank you once again for joining us today. And it just remains for me to say thank you to everyone and bring this session to a close. Thank you.
Thank you, David.
Thank you.
Thank you. Bye-bye.